of them? Do you track your sleep? What are the results? So nowadays everything is getting artificially intelligent. Sleep apnea, I can say, is one of the most, you can say, alarming towards dentist and more alarming to a patient walking to your clinic. How many of you treat bruxism patients on your daily practice? Patients, do you have bruxism? How many of you ask? Okay. So do you ask your patients, are you suffering from sleep apnea? Only I guess one. Imagine a patient who's coming to you and telling bruxism. Doctor, I cannot sleep at night. Do you not think he might be snore apnea? Definitely he is having a sleep problem. And that is something which is alarming. The starting point of your full mouth rehabilitation, or a patient coming to your clinic having something called as a wasting disease, that is atresion, abrasion, erosion, effraction, the first question which you should shoot is, are you having trouble sleeping? Are you having a night where you wake up tired? Do you feel heaviness in your body when you wake up? These questions will answer and take your patient to a shop. Yes, doctor, I feel all these things. This patient is surely a sleep apneic patient. And in medical science or in dental science, sleep apnea is related as a silent death. And we as oral physicians are the first point of contact towards giving them a right treatment. So without wasting the time, I would like to invite Dr. Avinash sir on the stage. I would like Dr. Parmeet sir to read out his introduction. Avinash sir, stage is all yours. May I have a round of applause for Dr. Avinash?
Sir, it's an honor to read the biodata because normally we see a crowd which have been forced by college HODs and deans. Please come and fill the audience, but this is an audience which has come only to listen to you.
Wow.
So we have our very own Dr. Avinash sir, specialized in oral medicine radiology. Imagine the knowledge sir has diverted himself from just diagnosing with your radiographs in CBCT and learning so much about sleep apnea. BDS from Amravati University and MDS from prestigious GDC Mumbai, lecturer at GDC Mumbai, and now sir was a professor head at Vasundhara Patil Sangli till 2023. He was an examiner at various subject selection committees, amateurs and other state universities, practicing more on oral medicine radiology, pathology detection, OMDR, TMD problems, occlusal spin therapy and implantology. Conducted many state and national level workshop, TMD workshop, orofacial by Jeffrey Okeson, fellow of Indian Society of Implantology and also a mastership implant program fellowship. So it's an honor. You see, there's a mixed crowd of fresh pass with BDS, postgraduates, practitioners, senior practitioners and retired practitioners who's just come to listen to you to take care of the sleep which they are not able to achieve or they are not able to provide the sleep. So the stage is all yours. Thank you very much.
Thank you, sir, for such a wonderful introduction. And I welcome all the delegates. And there are many stalwarts in the dentistry and there. So all the subjects. So specialists are there, and dentists, general dentists, they are specialists in all the branches. Yes. So basically, when you go to our dental clinic, we do the dentistry. That is comprised of all the subjects. Okay. So that is each of all the subjects, and we form the treatment plan. So without wasting our time, we just starts with the presentation. Okay. So it is a Sunday morning. It is a big crowd is there, and तो क्राउड बड़ा ज़्यादा रहता है तो उतना चेयरफुल होता है. तो अभी जितना क्राउड बड़ा है तो मुझे वेरी हैप्पी because 25 years back this subjects was like, मैं जब practice चालू किया था जब तो लोग बोलते थे TMJ explain what is this what like that. Now today after 25 years I feel there's the importance of this subject and I found the importance of this subject 25 years back. Why? I tell you. Okay. So I'm thankful to all the participants and delegates here who are present here for this wonderful program. Then IPS, IDA, Mumbai branch and the Denticare for this opportunity. The topic of today's lecture is obstructive sleep apnea, what, when and how diagnosis and management in dental practice. Okay, this is very important because obstructive sleep apnea itself is a very big subject and many medical specialists are behind that. But when I attended last week, I attended international conference on sleep surgical medicine. Then that conference, every hall, everyone talking about the dentist. 40% of the lectures and the treatment were on the dentist and the treatment. So that was the proud moment. One picture I'll just click, I'll show you. So they are saying surgery is not 100%. Okay, we cannot give them. Many people after surgery, they again develop the problem. So before going for any surgical steps, we need to do all the preventive things in your practice. So we dentists are not only doctors for teeth and gums. Okay, who are we? So मेरे साथ सब लोग बोलोगे अभी. But also we are physicians of masticatory system. बोलो सब लोग physician system. Because जब तक ये feeling हमको आएगा नहीं ना, हम आगे जाएंगे नहीं. So this feeling I got in after I finish my post graduation. Now this photograph is from the textbook Dawson. All the postgraduates know it. So they have said masticatory system. So masticatory system is compromise of TMJ, teeth, muscles of mastication and the ligaments. So it is not the masticatory system here. Because when you open the jaw, it's not the only lateral pterygoid which contracts. Along with the lateral pterygoid, what happens? The supraoid and infraoid group of muscles are also activated. So your area is still neck. So you are the physicians of masticatory system. The stability of the masticatory apparatus is very important and it depends on the structural stability of its components. So what is the meaning of this? So what happened? If the age changes, we say attrition is there, TMJ goes. So जैसे हमारा knee joint घिस जाता है तो हम क्या करते हैं? Knee replacement, yes. Because we bring back the structural stability. Same way, if the structural stability goes, we need to bring back it. Because what happened? If the attrition is happening, what is happening? Attrition हो रहा है तो क्या हो रहा है? किसका साइज बदलता नहीं है? टंग का साइज कभी बदलता नहीं है. टंग एट्रीट नहीं होती है. सो हम क्या कर रहे हैं कि टंग उतनी है बट एट्रीजन से क्या हो रहा है? टंग का साइज कम हो रहा है. वेयर द टंग विल गो? वेयर द टंग विल गो? बैक. यस, बिकॉज टंग स्पेस. सो वी नीड टू ब्रिंग और वी नीड टू गिव बैक द टंग स्पेस. इतना ध्यान में रखना है. दैट इज आवर रोल, to provide a room space, adequate space to the tongue. If you don't give the space to the tongue in the front, it will go to the back. Okay, that is the main cause of the sleep apnea. Now, आपने ऊपर logo देखा है अभी? See here, the logo is there. What is this? Dentist is comprised of TMJ, occlusion, airway, and the posture. So dentists play a great role in this. How I'll explain by evaluation, examination, and showing some cases. So आज सर ने भी जैसे शरीफ सर ने बोला कि मेडिको लीगल केसेस भी हो रहे हैं. बिकॉज क्यों हो रहा है कि हम जैसे सर्जन जो है एनेस्थेटिक जो है, कोई भी केस करने के पहले क्या करते हैं? प्री एनेस्थेटिक और प्री सर्जिकल इवेल्युएशन. दैट डेंटिस्ट वी डोंट डू. हम सीधा केस चालू कर देते हैं. बट अगर आपने इवेल्युएट किया है कि पेशेंट को स्लीप एपनिया है, पेशेंट को टीएमडी है, ऑक्लूजल प्रॉब्लम है, और पेशेंट को आपने बोला है और बाद में चालू किया है, और पेशेंट ने अगर उसमें ट्रीटमेंट नहीं भी किया तो चलता है, बट आपने पेशेंट को डायग्नोज करके बताया कि प्रॉब्लम थे. दैट इज मोर इम्पोर्टेंट. evaluation of all these four structure, TMJ, occlusion, airway and posture, and try my level best to because 1 hour in this time, this much big topic, because एक महीने से इसके पीछे लगा हुआ, because ऐसा lecture मैंने नहीं लिया, this is my first lecture, this type dentistry and the sleep apnea. So 1 month I'm behind this.
मुझे भी भेजना ये लिंक.
So Dr. Sayagita knows it. Thanks to her. And so whenever we understand and collaborate all these four into your case, I'll tell you, it will be 100% successful. There will be no failures. I'll show some cases of 14 years of the follow-ups. Okay. My journey of the TMD started from prestigious government dental college hospital in May 2001. I joined as a postgraduate student, and I'm thankful to my teachers and PG teacher, Dr. Annie John madam and Dr. Umarji sir. Okay. Now that time the topic was of this dissertation was, that was CBCT was not done, it is on the CT scan. So TMJ evaluation of osteoarthritis and rheumatoid arthritis on the CT scan. It was the topic, and that time I realized out of 100 patients, 30% of the patient is having severe osteoarthritis, and that time I realized the problem is very big. After that, I had done a lot of training in occlusion, DTR, T-scan, and EMJ from Robert Custine. Then on the digital occlusion in restoration and implant. Then again DTR workshop, body balance workshop from Dr. Tatis. Then Dr. Jeffrey Okeson was present in India in Prosco conference 2 times. Attended that pre-conference workshop in 2014 and at Raipur in 2019. And this ICMO is an organization, I attended their conference in 19. It was during COVID time, it was I think 21. It was offline due to the COVID. So it opens my eyes, ICMO. And 2023 at Goa, I attended the conference also. So it was more focused on the airway, TMJ and the occlusion. And this is the neuromuscular occlusion workshop by Prabhu Raman. And this is, so if you want to learn sleep medicine, Dr. Satish Balgar sir is the best in Mumbai. So 1 day workshop he conducts and it gives a lot of things. So please do attend his workshop. Then I just recently, last week, I attended this international conference on sleep surgical societies. Okay. So this is my TMJ. I have 2 clinics. One is conventional dentistry, one is specialized dentistry. So here I practice only DSD, that is by Dr. Sayogita, TMJ, FMR and dental implants. So more focus, 70% focus is on the TMJ. This is Dr. Sayogita, she is DSD specialist and she is in the board of directors of ICD. This is my clinic. We have an in-house lecture room. We going to conduct courses 3 to 4 days, in-house lab. Okay. So now this is a famous quote. If you fail to plan, you are planning to fail. Okay. So then I made my own quote. If you fail to diagnose, you will fail to treat. Because unless and until you don't diagnose, nothing is going to happen. Because you are not treating the cause or etiology, you are just treating the symptoms. So there are the new verticals in dentistry, TMJ, TMD and OSN airway. These are the new verticals. So for the OSA, medical practitioner and dentist work together for the OSA management. So in the medical team, sleep specialist, ENT, respiratory physician, allergy specialist, speech therapist, physiotherapist, sleep study labs are there. Then in dentistry, pedodontist. Pedodontist plays a great role in the prevention of the sleep apnea in the childhood if the patient is diagnosed early. Orthodontist, prosthodontist, OMR specialist, TMJ specialist, sleep medicine dentist, oral surgeons and the dental labs. Okay. So this is the prevalence of the OSA in the India. Okay, you can see here. Based on these findings, 104 millions of Indians working age suffers from OSA, of whom 47 millions are moderate to severe OSA. Okay, so this presents a major public health problem in India with an important implication in global burden of the disease. Maybe 10% of the population may be having sleep apnea, and In child it is 5 to 7%. In the US it is 2 to 4% for the woman and 4 to 9% for the men. So sleep breathing disorders remains undiagnosed in approximately 93% of affected women and 82% in the affected men. It goes undiagnosed. Why good sleep is important? It promotes growth, helps heart health, supports weight management, help combat germs and keep your immune system strong, reduce risk of injury, increase attention span, boost memory and the learning. Why it is important for us to know about airway? Okay. So first, OSA patient may not come directly to the dentist, so need to screen each your OPD patient for OSA and TMD. This I am going to take shortly, how to screen the patient. If you are going for any major treatments like bite changes, vertical change, dimension change, full mouth rehabs, orthodontic treatment, myofunctional appliance therapy, occlusal spin therapy, orthotic, first you need to diagnose and evaluate the OSA, airway and TMD, and then you proceed for the treatment. If any of your old patient is having repeated fractures of the restorations and failure of the implant and implant restoration, pain in the orificial region, TMJ region, need OSA, airway, TMJ evaluation. Though it looks like a medical problem, we dentists are having a lot of role in the prevention and management of OSA along with the medical OSA specialist. This is very important. So this was the slide. I have taken the photograph of the slide from the last week conference. So what is written in it? The patient with persistent TMD or reporting sleep bruxism should be screened for UARS. UARS is this upper airway resistance syndrome, which is a type of OSA, and chronic nasal obstruction, especially where they are also have present with the forward head posture. Okay, so this you have a lot of patients of the bruxism, also TMD in your practice. Evaluate them for the sleep apnea. So and there's a TMD is there. So the role of dentist in the sleep apnea is very big. Everyone is aware of the anatomy. Just I will revise it. Okay. So here you can see uvula, soft palate, okay, and tonsils, palatine tonsils, tongue. Okay. And the dentist plays a great role for the oropharynx. So if you see the oropharynx, this is a big tongue. So it is only attached to the front and back with the two bones, mandible and the height bone. Okay, and it is a huge muscular structure. And this is a palatine, you can say palatine tonsil, adenoid is here, okay, and the lingual tonsils. So this whole area is under the control of dentist. So if you see the tongue is a muscular organ, and superior, inferior to the tongue, lot of muscles are there. Okay, supraid group of muscle, infrared group of muscle. So the spasm of that muscles also take the tongue back, or to the one side, to the right side, or to the left side, or if the change in the vertical dimension, in the occlusion or disc displacement, osteoarthritis, also reduce the vertical dimension, reduce the space for tongue. Okay. So these are the supraid and infrared group of muscles, and these are the tongue muscles: genioglossus, genioid, hypoglossus, and styloglossus. Okay. So functions of the supraid: depress the mandible and elevates the height bone, lowers the height bone and steadies the height bone. So this is the infrared group of muscle functions. So there are the red flag patients in your practice. So suppose this is a case, you can see here, cervical restorations are going off, the canine crossbite is there, and repeated fractures of the cervical filling at the age of 80 years, every 6 months the fillings was going on. What is the wrong in this? What do you feel? So if such cases are reporting to your practice, what you need to do? Evaluate the occlusion, evaluate the TMJ, and evaluate the airway of such patient before you proceed for the further treatment. This patient again, you can see multiple cervical, though the oral hygiene is good, multiple fillings and the root canals, is there. So such cases reporting to your practice, evaluate everything before you proceed for the treatment. This patient again, cross bite. So if the teeth given by the god does not stay, means something wrong is there. So you need to find out that what is the wrong and correct it, and then you proceed. This patient, deep bite, what is the problem here? Tongue space is again reduced. There is no guidances. Okay. So whatever the treatment, if you give a crown, that particular tooth is not going to stay. Okay. You need to evaluate the case completely with respect to the TMJ, airway, occlusion, and then you should proceed for the next. This patient. So this was the implant patient, and the implants were getting failed. What is the cause? So teeth given by the nature, they are not staying. You need to correct it. The problem, need to correct it. But before that, diagnosis is important. This patient, this was the recently done FMR, and patient reported to me within 6 months, fractures of the restorations. Occlusion is proper here? Occlusion is not proper. So one problem is solved. Okay? No proper occlusion. Second, this is the airway of the patient. You can see it's very minimal, black here. This is the grading scale of the airway: white, blue, green, yellow, orange, and red and black. So it is in the list. We'll see in that airway analysis. Okay. T scan of this patient, and T scan of the patient shows, you can see the forces, more forces on the right side, and in that this side. So here the less forces, so imbalance of the occlusion is there. So all the three factors, and the forward hedge posture also. So you need to evaluate it, because that's a failure. That's why then we land up into the medical legal problems. If you tell everything in the beginning, you will not land into the problem, because we told everything to the patient, this is the problem. So fracture of the implant, best company implant. Okay. So why my restoration fracture in spite of using the best material, best skill and the time? Because if you fail to diagnose, you will fail to treat. So your diagnosis was not there. Okay. So if you see, all these patients runs around all the medical specialists, okay, for the seek of treatment, for the treatment, but they don't get the results. Why? Because the problem lies not into the प्रॉब्लम कहाँ पे है? नहीं है. प्रॉब्लम कहाँ पर है? This area, and they goes to the medical specialist. Okay. So that's why it's very important to understand TMJ, occlusion, and the airway, because if you see the masticatory apparatus, teeth, muscles, and the temporomandibular joint, so if they are not in harmony with each other, they will affect the masticatory apparatus. Masticatory apparatus is attached to the body, so it will change your posture also. So we have a big role in this branch, airway and the TMJ. Okay. How I proceed examination in my clinic? So by doing a lot of study, we formulated the one pro forma, and this is patented also. Okay. So so then we examine the deviation, deflection, clicking, crepitus. Clicking, where do you get clicking? In this displacement with reduction. Where do you get crepitus? I'll show you that. In case of osteoarthritis. Okay, everything I'll show to you. Then TMJ examination we do. Muscles of mastication, temporalis, masseter, medial pterygoid, lateral pterygoid, digastric, sternocleidomastoid, trapezius, back muscle, chest muscle. We take the consent first of the patient. See this consent. We take the consent from the patient and then we do it. Please take consent of the patient before doing examination. Upper chest muscle and the lower limb muscle, lower part of the body. If the male, female patient is there, you ask your lady assistant to do it. Okay. Then also the occlusion, angles class 1, class 2, class 3, vertigo and tinnitus. Just note down it. One of the reason of the tinnitus is vertigo is this occlusion or TMD. So again the occlusal contacts, anterior guidance present, absent, canine guidance, curve of Spee, curve of Wilson, open bite, cross bite, deep bite, dental, everything you note down, and then this is a interferences. So working side, non-working, everything you should note down, and then on the basis of that you come to the diagnosis. It is a what patient is having TMD, myofascial pain, disc displacement with reduction, without reduction, and then after that I send the patient for the imaging. So imaging, closed mouth OPG. Normally how do we take a OPG? We keep the incisal tab and take. So what is this? There is a CRCO, हम जिसको बोलते हैं, centric occlusion and centric relation can be seen only on the either transcranial view or closed mouth OPG. So as the patient completely closed, you can see both the teeth and the TMJ together. Same way, if you are want to see the airway, you should ask for the closed mouth CBCT, closed mouth TMJ CBCT and airway. If you are doing the open mouth airway analysis, that is not accurate. Then TMJ, MRI, CBCT, then MRI if needed, open and closed mouth. Then I also advise spine X-rays, AP and lateral, to see the changes in the any spine. Okay. So there's a lot of questions, and there's a relation also, sleep bruxism. Okay. So what is sleep bruxism? We do the grinding in the night, and there are the two causes, peripheral and the central. Peripheral is the anatomy of the orofacial skeleton and dental occlusion, morphology and articulation, and central is the psychosocial problems like anxiety, stress, then physiologic conditions, and the sleep-related cortical and autonomic arousals and neurochemical alterations. So basically it is the psychosocial problem and the orofacial skeleton. So I'll just explain to you. And this is the pathophysiology of the emotional stress on the muscle activity. If you have an emotional stress, what will do? You do the bruxism. And there will be the muscles fatigue and the spasm. Okay? This was one of the article. Okay? So once the stress is there, bruxism is there. Okay. Second, coming to the etiology of the myofascial pain. Now you can see here the stress, oral habit and the dental irritants. Now just I'll explain in short. Suppose stress and tension is already there. Patient is doing bruxism and patient is having a good occlusion, means presence of anterior and the canine guidance. Even though you brux, the side effects will be zero or very less. Welcome, Varun. Okay. And suppose the patient is having the, you can say class 2, class 3 malocclusion, cross bite, anterior open bite, and patient is doing bruxism, the side effects will be too much. Okay, that's why it is related. So if the patient is doing bruxism and bad occlusion, it leads to the increased muscle hyperactivity and muscle fatigue and muscle spasm. Now this muscle spasm is again a problem. So again these muscles in this area get contracted, and that is again cause for reducing this tongue space. This whole, because it is interrelated, hide bone, everything is interrelated. It's not only the one structure or one part. Okay. So and all leads to the other problems. Okay. This is the diagram I always show to the patient while explaining. So our joint is like a nutcracker. So this is the TMJ, posterior teeth and the anterior tooth. Where do you keep a nut while cracking it?
Posterior.
Back or front?
Back.
Why? More forces near to the joint. Okay. So we have a forces of 100 to 200 pound during clenching on the back, and during in the front is 20 to 50%. Now what happened if the patient is having good occlusion like this, angles class 1, and there is a posterior separation, this occlusion is happening. So you can see all the muscle except the lateral pterygoid is slightly contracted. So if this patient is doing the bruxism, the forces of the bruxism will be like this, only 300 to 750 pounds. Now the second patient is having the anterior open bite or absence of the anterior and posterior anterior guidance. What will the forces during bruxism will be this much. This is the difference. So everyone does the bruxism, but it depends on how the occlusion patient is having. If good occlusion, there will be less side effect, bad occlusion, more side effects. And again it is depending on the disclusion time also. We just see the separation, but that separation is happening in how much time, that is also important. So occlusion, we need to see occlusal contacts, anterior guidance, canine guidance, occlusal curve, and there should be no interferences in your occlusion. So this, we normally say CRCO. So I told you how to see that, occlusal contact and the closed mouth OPG. Now this is the T-scan multi-bite. Here you can see the occlusal forces, right and left. It is balanced or not. Okay, this way we can see. You can see this patient left side, the forces are increasing. Okay, more on this 2728 region. Okay, this is 28% of force on this particular tooth. Okay, on this first molar, and patient was having a severe pain and sensitivity in that tooth. But suppose directly we reduce that, reduce that interferences before diagnosing or TMJ or other muscle issues, then you will not get the successful results. So first you need to evaluate why this is happening. So canine guidance, normally we say when the canine is in contact, posterior teeth are separated. But how much time is taking for separation? That is also important. So that we can see on the this T-scan right lateral. So right side canine guidance. So here you can see when the patient is taking the jaw to the right hand side, so posterior teeth are coming into contact. So D is the disclusion time here, and you can see how the teeth contact. So in this area still tooth contact is there, and then now the teeth contact in this area still there, still it is there. Okay, now they are going. Okay, so the time the mandible is taking to relieve the posterior tooth contact only coming to the canine. So that time is called the disclusion time. Here the disclusion time is 1 second. That is 2 to 3 times more than the normal disclusion time. So what happens if the long disclusion time is there? What will happen during clenching or bruxism? The more forces on the muscle will be there for a longer period of time, and that will cause the muscle fatigue. Okay? And with the help of Dr. Varun will comment on that EMG and T-scan, so to the hyperactivity of the muscle. Okay. So then the curve of P and the curve of Wilson, ये हम भूल जाते हैं, लैब वाले भी भूल जाते हैं. So लैब वाले को याद दिलाओ कि क्या है, because you need to give the occlusion in this curve of P. So there should not be any interference in the medial lateral and the anterior posterior direction. Third molar को देखो हमेशा, वो ऊपर रहता है. Don't use the third molar as an abattement. And lingual cusp of the lower should be at higher level or lower level. They are always at a lower level as compared to the buccal cusp. Curve of Wilson. ये follow करना है. ये हमको, और हम occlusion जब देते हैं patient को OP करना. Because everything leads to the hyperactivity of the muscles, and everything, even in the conference I listen, everything based on the muscle. So we need to relax the muscle and position the tongue. So Shimbashi method, so most of the people know about it. So when we keep the vertical dimension or in FMR or in ortho, even ortho is also full mouth rehab. We don't consider ortho as a full mouth rehab, but ortho has the same effect on the your oropmasticator apparatus. अगर पेशेंट के अलाइनमेंट में नहीं है, हम एक दो दांत निकाल देते हैं, पेशेंट क्या करते हैं, पीछे ले लेते हैं. So what we are doing? We are reducing the space for tongue, and patient will start the bruxism, patient will start the sleep apnea also. So, what is the Shimbashi? It is a distance between the upper central incisor to the lower central incisor, zenith or CEJ. Okay. It should be at least 18 to 20 millimeter. So, whenever you plan for the FMR, increased VD or ortho or anything, appliances also, so that distance should be more than this. This you need to keep in mind. This is my article published in the National Journal, Evaluation of Dentition Status and TMJ Disorder in Patient with Chronic Head Neck Back Pain. So in this, what we have done, we have taken the patients from orthopedic OPD like head neck back pain and evaluated TMJ and occlusion in that, and the posture also. So, and then we have given the appliances to them, and their head neck back pain reduces. we have done this on 300 patients. So there is a relationship of the occlusion, TMJ, head, neck and back pain. Okay, so it related. So this available on the net. So this patient, this is a medical student. Now she is medical student reporting to me, and she, if you see, she was having this occlusion. Okay, so now we need to evaluate what? TMJ, occlusion, airway and the posture. Okay, fourth thing. So now, if you see the occlusion in the closed mouth, what is the problem here? There is no contact. Only contact we can see here. Okay. Now, what we'll do most of the time? We grind out the contact. What will happen? See, now just look at here. What is the problem? Joint space on the left hand side is less as compared to the problem is into the TMJ, not into the anterior open bite. So now this patient is having mandible is this like this. So pushpa. So ये ऐसा हो जाएगा. So we consider ये क्यों हुआ है? We need to first find out dental cause. TMJ. This is the T scan of this patient, and we can see the more forces are on the left hand side, and only where you can see only few teeth are into contact, no occlusion. So we think of doing ortho or posto in this case. No, first solve the problem of the patient. This is the airway of this patient. So this airway is good, but you can see the nasal obstruction. There is a problem. So we evaluated everything. This way, simply by doing CBCT and clinical examination, you can evaluate everything in the patient. Okay. TMJ evaluations. So this is my form that I am taking. Dr. Varun will concentrate more on that. So just examination of the muscles of mastication and the clicking. What deviation? Deviation is there. 3 clicks in one joint, both the side. So clicking is normal. Clicking normal होता है? No. Then everyone should have click. Clicking is not normal. So if your patient is having clicking in the joint and deviation, your diagnosis is this displacement with reduction. Okay, so these are the different videos. Okay, so just why I wanted to show these videos here. So if you see the disc is displaced anteriorly, the joint space reduce. So if your vertical dimension reduce, what will happen? The space for the tongue will reduce. Okay. Same way, this is a disc displacement with reduction, here without reduction. And next level, we can do MRI if you wanted to see the disc displacement. Okay. So this is the normal one. Ubota appearance you can see in the normal. Then the coronal section, and this is the dynamic MRI. Okay. So why the videos are not running?
Click करो लगे.
वीडियो वहाँ से मुझे ऑपरेट करना है. नहीं रहना है. Click करना. Pseudo dynamic is not a dynamic, it is a pseudo dynamic. It is made from the, you can say, files, and you can see the moment here. एक बार प्ले करो. दोनों प्ले करो, दोनों वीडियो. Okay, you can see the bow tie appearance here when the patient opens the mouth. That shows the normal MRI. और एक बार पीछे जाओ थोड़ा. पीछे. Sorry. हाँ. हाँ. बीच वाला वीडियो. बीच वाला. So when the patient opens the mouth, it hits the disc. That's why you get a click. Okay. और जब हम close करते हैं तब. So disc is displaced. It is not in a normal position. When the patient opens the jaw, head of condyle hits it. That's why you get a click, and while going back, you get a click. So it is not a normal at all. And if you don't treat, it will land up into the next level of the, or next progression of the disease. That is without reduction. Okay. Now, if you don't treat at this level also, it goes to the next level, that is the osteoarthritis. ये रन करो वीडियो, दूसरा वाला करो, बाजू वाला, वो चालू करो. Listen to this sound. This is the sound of crepitus. अभी ये पहला वाला करो. So long grating sound. So this because the bone is rubbing to each other. So again this related to the decreased joint space. Okay. So osteoarthritis is a very severe case to treat. Now this girl, 22 years old, complaining of the clicking since last 5 years and difficulty in chewing. She went to the dentist. Dentist told her everything is normal, don't worry. After 5 years, she landed up into this situation where you can see the joint space is okay here. It is less. Again, the jaw is tilted. So see so what is happening here to the TMJ is over now. So अगर हम 5 साल पहले उसको रोक सकते थे तो ये situation नहीं होता था. So that's why it is very important to know about the diagnosis. So everything is related to the airway. This is छोटा सा airway and the TMJ. How the airway and TMJ affect the posture of the patient.
Reduction of the disc, and then shift back to an incorrect forward position upon closing. This is what causes a reciprocal click. In addition, the muscles could be in a state of hypertonus or spasm, which can result in tension headaches. An incorrect position of the lower jaw can result in parafunctional activity of the muscles, such as clenching and grinding. Over time, grinding can result in severely worn down teeth. As a result, the teeth become even shorter, the lower jaw shifts distally even further, and the vertical of the bite decreases. In time, joint degeneration occurs. The joint becomes deformed, and the ligaments of the joint become damaged. As a result, the TMJ disc can get trapped in front of the condyle. While the click may go away, limited mouth opening will occur. A distally shifted jaw and tongue positions result in even further restriction of the airway. In order to open up the airway, the neck moves forward and the head tilts backward. This stresses the spine and fatigues the neck muscles, which results in neck, back, and shoulder pain.
So how this is the TMJ airway is related to the posture. So now this was the pro forma. What I was telling you, how I take the case history of the patient. So it take nearly 2 hours for me. 2 घंटा लगता है पूरा करने को. But routinely you can do in your just ask the question, just do the palpation. So at least we'll come to know that patient is having. Why ये play करो. Why nasal breathing is health is very good.
The normal or physiological way of breathing is through your nose. Breathing through the nose permits to purify the air by the structures inside the nasal cavity. In that way, the air entering into your naso and oropharynx, your throat, is not going to heavily affect the lymphoid tissue in the adenoids and tonsils, which is the last barrier to catch harmful particles in the air before it reaches your lungs. Besides clearing the air from harmful particles, nasal breathing stimulates the production of gases and substances in the nose, which are going to facilitate the entrance of the air in the lungs and prevent infection in your respiratory system. Mouth breathing allows the air to pass directly into your throat, where the adenoids and tonsils are located. In that way, the air entering into your body through your mouth has not previously been purified, and the lymphoid tissue in the adenoids and tonsils become the first defensive barrier against the harmful particles contained in the air. As a consequence, that lymphoid tissue overgrows, occupying a large volume of your throat. That makes more difficult for the nasal breathing, and you make a habit of breathing through your mouth. In order to breathe through your mouth, your lower jaw has to come down, as well as your tongue has to rest on the floor of your mouth. Breathing through the nose is the correct way, and so the tongue is able to rest on your palate, stimulating a normal growth and development of your upper jaw. Conversely, when you breathe through your mouth, your tongue has to descend and protrude. At the same time, the pressure of your cheeks increases, pushing the upper jaw inwards. So the growth and development of your upper jaw is negatively affected, resulting in a narrow and high palate. The upper dental arch acquires a V shape instead of being a rounded dental arch. Therefore, your teeth do not have space to properly align. This also produces an incorrect swallowing function. Every time you swallow, between 1,600 to 2,400 times per day, the tongue positions low, staying away from your palate. That forces the tip of your tongue to position between your upper and lower front teeth. That pushes your front teeth to show out of your mouth and your tongue resting on the floor of your mouth with the tip of the tongue between your front teeth. That is called an open bite, as your upper and lower front teeth do not touch when you close your mouth. All those dysfunctions, mouth breathing, incorrect tongue posture, open mouth, and incorrect swallowing are going to continue affecting the growth and development of your upper and lower jaws. And as a consequence, there is less room for your teeth and they become crooked. Remember, the nose is for breathing and the mouth is for eating. Breathing through your nose and keeping your mouth closed with your lips together is going to help your upper and lower jaws to grow and develop better. But more importantly, it makes you healthier.
So these are the consequences of the mouth
Mouth
breathing.
breathing.
But why do you breathe through the mouth? Is again there's a problem. Why? Because most this if you diagnose early in the childhood, so we can prevent the future sleep apnea patient. So that's why I told you pediatric dentistry has a great role in the, you can say, prevention of this. So just we need to find out why it is happening. So if you do the clinical examination and airway CBCT analysis, you will
The
know
normal-
So sleep-related breathing disorders are a group of disorders that is characterized by abnormalities of the respiration during sleep, and they are called as SRBDs. Okay. The third edition of the International Classification of Sleep Disorders classifies SRBDs into the four major categories, that is OSA, CSA, sleep-related hyperventilation syndrome, and sleep-related hypoxemic disorder. But we are only concerned about the OSA disorder. These are not our you can say territory. This is the medical territory. We are only focusing on the adult OSA and the pediatric OSA. Okay. So OSA is characterized by repetitive, complete or partial collapse of upper airway during sleep, causing a cessation, that is obstructive apnea, complete cessation, okay, of the breath, and or significant reduction, that is of airflow, that is obstructive hypopnea, apnea and the hypopnea. So breath can completely stop or partially stop. That is apnea and the hypopnea. And apnea hypopnea index can be observed as seen by which method or study, you know?
Sleep study.
Sleep study. Sleep study will tell you, that is polysomnography, will tell you this index. And on the basis of this index, you can say sleep apnea, you can categorize mild, moderate and severe. Okay. So initially, occasionally the patient is snoring just, then habitual snoring, then upper airway resistance syndrome will happen, and occasional apneas or hypopnea, and then OSA syndrome will develop. So this way is happened. Okay. So upper airway resistance syndrome. So this initially it is like this. So what is that? Abnormal respiratory effort, nasal airflow limitation, minimal or no oxygen desaturation. So greater than 90% oxygen saturation and frequent sleep arousals in the absence of obstructive apneas. Okay. Untreated diagnosed UARS patient over a 4-year period were found to have increased symptoms of daytime fatigue, insomnia, depression, increased sleep disturbances. Okay. So the first line treatment for this CPAP. Again, it is depend on the sleep study. So what is the pathophysiology of OSA? OSA is caused by soft tissue collapse in the pharynx. Anatomic factors like enlarged tonsils in children, volume of the tongue, soft tissue, lateral pharyngeal wall, length of the soft palate, abnormal position of the maxilla and the mandible. Again, the class 2 and deep bite cases prone for this. Etiology is structural factors like innate anatomic variations, retrognathia, micrognathia, mandibular hypoplasia, brachiocephalic head form, inferior displacement of the eye, adenotonsillar hypertrophy, particularly in the children and the young patient, young adults, Pierre-Robin syndrome, Down syndrome, Marfan syndrome, Prader-Willi syndrome, high arch palate, okay, particularly in the woman, and again the nasal obstruction. So if the nasal obstruction is there, again the patient cannot breathe through the nose. If patient will breathe through the mouth. So nasal obstruction like polyp, septal deviation. So most of the thing this polyp or nasal obstruction is due to the some allergic reactions or allergy is there. Retropalatal obstruction, elongated or posteriorly placed palate, uvula tonsil, adenoid hypertrophy, and retroglossal obstruction is due to macroglossia and a tumor. Okay, so these are the different etiology present. ये पहले वाला ऑन करो, सॉरी पहले वाला वीडियो ऑन करो.
If you're someone who snores, chances are you've wondered if there's a way to make that classic sound go away. Why do we snore anyway? When we sleep, tissues in the back of our throat relax. That narrows the airway so that each breath is now being pushed through a smaller space. As the air rushes past these collapsed tissues, it causes them to vibrate, and these vibrations are the raspy, wheezy sound we call snoring.
Second one. So basically, if the reduced breathing is there or reduced oxygen supply is there, what will happen? So all the organs in the body will not get sufficient.
If you're someone
sufficient oxygen, and the healing of the organ will not be there. So then you will be tired. So अगर कोई गाड़ी हमने एक 1000 किलोमीटर चला दिया, उसको रेस्ट नहीं दिया, फिर से हम चला रहे, तो क्या होने वाला है? So there is no rest for the repair. So what will happen? Engine will get fatigued and not give the performance. So what are the clinical examination in this sleep apnea patient? So extraoral examinations are signs of excessive sleepiness are unexplained daytime sleepiness. तो आपने अभी बहुत लोगों को देखा होगा कि बैठे बैठे सो जाते हैं, टीवी देखते देखते सो जाते हैं, बात करते करते एक दो सेकंड के लिए ऐसा नैप ले लेते. So that is what the daytime sleepiness. Droopy eyelids, repetitive yawning, frequent changes in position, blank facial expression, irritability, signs of OSA, obesity, assess weight by BMI, large neck circumferences, nasal examination, deviated nasal septum, turbinate hypertrophy, cervicofacial angle, retrographic, micrognathia, thyroid size. Signs of the TMD we have already seen, TMJ masticator. Risk factors for the sleep disorder breathing, masticator muscle tenderness. So again muscle fatigue. Intraoral evaluation, oral health, dental and periodontal status, mouth opening, then baseline panoramic cephalometric radiographs is important. So we already saw that. Risk factor of the OSA, evaluation of the upper airway with the soft palate, tonsil, uvula, pharyngeal layers, tissue space, airway tissue, tongue, and Malampatti score. Malampatti score I'll take. Signs of SBD bruxism, tooth wear due to grinding and cheek clenching, indentation on the tongue and the buccal mucus. Okay. Signs of the GRD, so prosthodontists know it well. Erosion of the enamel and exposed underlying dentin, sensitivity to the temperature. So अगर आपके दांत अंदर से worn off हो जाते हैं, attrition नहीं रहता है, worn off हो जाता है, that is GRD, esophageal reflux we say. So gastroesophageal reflux. So screening of the sleep disorders. So record sleep history and the symptoms related to sleep disorder. Chronic snoring. You just need to ask to the patient. Previous surgery है, night awakening due to air hunger, noisy breathing while awake. मतलब अगर बहुत बार अपने लोगों को देखा होगा, अपने बाजू में खड़े रहते हैं. You feel that sound. Okay. Noisy breathing, non-restful sleep, difficult awakening, nasal congestion, dry mouth, nighttime cough, nocturia, daytime sleepiness, chronic weakness, libido symptoms, headaches, memory and concentration deficit, and reports of the partner. So you can ask the partner is snoring or not, or he or she. Then evaluate comorbidities of the lifestyle habit and sleep history evaluation. Okay. So this screening you need to do, or if you send the patient to the sleep medicine or sleep physician, they will also evaluate for it. Okay. The common signs and symptoms in pediatric OSA. So frequent snoring, labored breathing during sleep, gasp, snorting noises and observed episodes of apnea, then EDS, excessive daytime sleeping, sleep analysis, sleeping in a seated position or with the neck hyperextended, cyanosis, headaches on awakening, attention deficit hyperactivity disorder. What is this? Yes. So they are saying in the adults, we are fatigued or tired, but children there is opposite. So ADHD again indicated that patient may be having sleep apnea, ADHD. So physical examination, we need to see tonsillar hypertrophy is the most common. Underweight or overweight, adenoid faces, micrognathia, rectognathia, high edge palate, failure to the hypertension. So need to evaluate all the things if the patient, child patient is doing the having the sleep apnea. Okay, then the indentation on the tongue you can see, and the enlarged palatine tonsil. Okay. Now this you can take the photo. This you can do in your clinic also. There is a stop bang questionnaire. Okay, stop. Snoring, tired, observed pressure. Then bang is the body mass index more than 35 kg per meter square. Then age older than 50 years. Neck size large and gender. So if you get a score of, so we started at 10. Columpati classification. You ask the patient just to open the mouth. You can do also yourself, and just need to check for the soft palate and the uvula. Okay. अगर soft palate uvula clearly दिख रहा है, this class 1, uvula थोड़ा दिख रहा है तो class 2, base of the uvula दिख रहा है तो class 3, and soft palate is not seen, this class 4. So this class 3 and class 4 they are more prone for the, you can say they are more prone for the sleep apnea. Okay. Then tongue tie and the sleep apnea, is the relation or not? So this is the classification for the tongue tie. You can see classic tongue tie. So what happened if the tongue is properly positioned? There is no tongue tie, it touch to the palate. This is the normal position of the tongue. If the tongue tie is there, it will bend from the back and encroaches the pharyngeal area. If you release the tongue tie again, tongue posture may come to, but again it requires the myofunctional therapy for it. So this we already covered. So investigations, this is the most important, is the sleep study. Okay. So levels of sleep studies, level 1, level 2, level 3 and level 4. Level 1 is done in the lab only, level 2 in the lab and the home also. So level 1 and level 2 difference is in the level 1 we can do videography of the patient. This is the sleep study they do in the lab setup. Okay. Then what we get from that is the apnea and the hypopnea index and the RERA we get. So if the AHI index is less than 5, it is a normal one. AHI index is 5 to 15 is a mild sleep apnea. 15 to 30 is a moderate, and more than 30 is the severe. Okay. So this is the diagnostic criteria. I will just rush forward. So 10 minutes in my hand. Okay. So these are the consequences of the OSA. Okay. So how I proceed? I take the case history and clinical examination, CBCT error assessment, and consultation. If after that I require sending the patient for the consultation to the ENT or the sleep specialist. Once the patient comes to me after CBCT, if the airway is less, so I take the 2 bites. So which type of the spray I need to give to the patient and send for the CBCT. Once I get the report, I do the planning for the treatment. Okay. So the tailor treatment. So our aim is to expand the limited space in the upper air. So these are the different studies. Behavioral treatment. So CPAP and BiPAP and appliances. Anterior reghosting splints. So anterior repositioning splint worn for extended period of time can lead to the irreversible fibrotic contraction of the superior lateral pterygoid muscle, and there is a common tendency to form adhesionous scar tissue formation behind the condyle. So you can give anterior repositioning splint for few times. Again, the TMJ symptoms may get aggravated. So what to do for that? So airway classification. So airway we send for the CBCT, airway analysis, and you can see this airway here, the soft palate, epiglottis, then here is this pharyngeal adenoids is there, nose is there, okay. And the oropharynx is palate and tonsil. Again, enlarged palatal tonsil here. You can see on the CBCT. So this is the classification is copyrighted by Dr. Ajay Naik. In that you can see grade 1, 2, 3, 4 on the basis of the constriction in the particular area. Suppose we take it is a mild, moderate or severe. If the airway space, least surface area on the axial CBC section, it is more than 200 is 0, is 151 to 200 is a grade 1, 100 to 150 is grade 2, and this is 50 to 100 is grade 3, and 1 to 50 is a grade 4. So this is the area. So there are two areas behind the palate and behind the tongue, and G is the combination of the both the things. So on this basis we can grade the airway of the patient. Okay. So these are the different grading system. You can get it from Dr. Ajay Naik. Okay. And this is CBCT airway analysis. Okay. This is the 3D CBCT airway analysis. Normally what medical people used to do to evaluate this, they do the drug-induced sleep endoscopy. So that is more dynamic, because this whatever the airway we get, it is in the standing posture. When patient sleep, again the airway reduces. So जो भी हमको airway यहाँ पे मिलता है, उससे वो sleeping में ज़्यादा ही रहेगा, मतलब short रहेगा, कम रहेगा. So this is the normal airway. Case 2. Now this is the case where you can see here, airway is reduced. Okay, how much it is? So it is airway 65.3 mm. Okay. Now I done the 2 bites. I take the 2 bites. One is the forward position. How much patient can tolerate? Okay. So forward position and the vertical also. Not only just forward. So forward and vertical also. And second is just the vertical in the Shimbashi. Shimbashi को follow करके हमने लिया. I take with the acrylic the pathogen you can use. Place it, make a bite, and send with the patient with the bite to the CBCT center. So this we can say here, the area is increased. Overall volume here is a 22. Here volume is 21. So volume is increased. Minimum area is 59 and it is 65. So this area is not increased. But if overall you see, the airway volume is increased. And here area is 63. So here again volume is increased, but area is also increased. So we can think if the patient is having TMJ patient and patient is having the sleep apnea patient. So you need to give the 2 types of splint to the patient. Those splint आपको देना पड़ेगा उसको. But how to do? I normally follow. There are the different criteria, but I normally follow. If the TMJ pain is severe, then I ask the patient to wear the alternate day or 2 days, one splint, 1 day, one splint, depending on that. So which symptom is more severe, patient should wear that splints more, or only sleeping during sleeping at the time of the sleeping airway splint, and the rest of the time TMJ splint. Depend how which symptom is more severe. Okay, then again we will come to know the nose bite, come to know the thing. This is the anterior position bite. So this much mandible is coming. Right. Okay. And this is the occlusal analysis of this patient. This type of the bite, okay, and the airway. Airways, this is the anterior reposition bite, and this is the central bite. This is very interesting patient. So this is, you can see here the airway, how much it is, 78 or something. Volume is 11 mm. So now what I have done, initially I was doing this. I given a bite. It was a wax bite completely, and it was depressing the tongue. So I thought it is reducing the airway, and with the anterior repositioning bite, you can see a good airway increase. Okay, so I given the anterior spleen to the patient, and this is the bite of the patient. You can see here the bite is also changed. Okay, so this was the patient OPG, closed mouth, and these are the different spleens. Okay, after 4 months of patient complaining of wearing the anterior spleen, patient complaining of the discomfort in the with the anterior spleen. So I had taken again the airway, and the airway is reduced with the anterior spleen, but it was good with the stabilization spleen, centric bite. Okay. So this is 4 months after. This is the previous one. This is same, the closed mouth. So you can see the improvement in the airway. Closed mouth, it is a closed mouth. You can see improvement in the airway, and this is after 13 months. Closed mouth. How was the closed mouth before this? With the anterior reposing spleen, and after 4 months, stabilization spleen. So even the nasal blockage was there, that also reduced. So I not patient is not taking any antiallergic, still it reduced. After 13, you can see here nasal blockage. It is improved. So if you increase the airway, and again here after 13 months the TMJ is again stable, you can see. So you need to consider and posture of the patient. Posture is also of the patient is improved.
लास्ट ईयर जनवरी में 2025 जनवरी में मेरे पास आए थे, तो आपको तब क्या क्या तकलीफें थी, सब मतलब डेंटल की और मेडिकल की जो भी तकलीफें आप बताओ।
मैं आया था तो मेरे को स्टार्टिंग में जो मुंह खुलता था तो कट आवाज आता था, उसके लिए आया था। और दूसरी प्रॉब्लम भी थी, थोड़ा हियरिंग लॉस था, थोड़ा सर दर्द देता था मेरे को, और हाथ में नमनेस जैसा लगता था। काफ़ी प्रॉब्लम थी मेरे को बैक में भी पेन था, पैर में भी पेन था, यानी पूरा सब जगह प्रॉब्लम ही प्रॉब्लम थी। एंजाइटी मेरे को आया था, उसके 1 साल से एंजाइटी का प्रॉब्लम, 2024 से एंजाइटी का प्रॉब्लम था। फिर डायबिटीज तो मेरे को 25 ईयर्स से, और बीपी भी 25 ईयर्स से। मेरे को 2021 में मेरे को एंजियोप्लास्टी स्टेंट डाले हुए थे।
It was a chronic sleep
मेडिकल प्रॉब्लम थे, लेकिन अभी एंजाइटी 2024 से एंजाइटी का प्रॉब्लम हो गया था। नींद भी नहीं आती थी बराबर मेरे को, और हियरिंग लॉस का प्रॉब्लम था। फिर मेरे को वर्टिगो का प्रॉब्लम चालू हुआ, तो डॉक्टर ने मेरे को दूसरी स्प्लिंट बना के दी। पहला अपर की दिए, उससे मेरे को सब कम हो गया, फिर नीचे की स्प्लिंट दी।
after 4 months.
इससे मेरे को, मैं चलता था तो मेरे को चक्कर आती थी, बैठा रहता था, प्रॉब्लम थी।
नोज का जो सूजन था, नोज में भी सीटी स्कैन पे सूजन था।
मेरा नाक भी ब्लॉक रहता था, और मेरा एयरवे भी सीबीसीटी कराए थे हम लोग ने, तो उसमें तब एयरवे भी ब्लॉक था मेरा, बहुत ज़्यादा ब्लॉक था मेरे को। वो भी डॉक्टर ने, ईएनटी वाले ने तो स्लीप स्टडीज़ का भी बोला कि मैंने कराया नहीं। डॉक्टर ने मेरे को बोला स्प्लिंट पहनो, इससे तुम्हारा एयरवे खुल जाएगा। तो हम लोग ने 2-3 महीना पहन के फिर वापस कराया सीबीसीटी, तो मेरा एयरवे बहुत अच्छा खुल गया। मेरे को लगता है 2 महीने के अंदर ही खुल गया। उसके बाद वापस सीबीसीटी कराए तो हम लोग एयरवे अच्छा है। और आज भी मैंने सीबीसीटी कराया, मेरा एयरवे नोज का ब्लॉकेज सब खुल गया।
1 साल बाद
1 साल बाद मैंने काफ़ी फर्क गिरा है। सोच नहीं सकते कि ये ऐसी चीज़ स्प्लिंट पहनने से ठीक हो सकती है। वर्टिगो और चक्कर का तो इतना प्रॉब्लम था कि समझ में नहीं आता था। मैंने वर्टिन 16 कितनी गोलियां खा लिया हो, खुद को नहीं मालूम। दिन में 2 गोली वर्टिन 16 खाता था, काफ़ी टाइम तक मैंने खाया हूँ। बहुत टेस्ट कराया, कुछ समझ में नहीं आया, लेकिन ये डॉक्टर मेरे को कॉन्फिडेंस देते बोले स्प्लिंट पहनोगे, तुम्हारे को आस्ते आस्ते करके थोड़ा टाइम लगेगा, लेकिन अच्छा होगा। मेरे को कॉन्फिडेंस आया और मैंने पहना तो मेरे को फर्क गिरा। फिर आस्ते आस्ते करके मेरा रिकवर हो गया, ऑलमोस्ट 90% मेरा रिकवर हो गया। चक्कर का प्रॉब्लम, वर्टिगो का प्रॉब्लम।
और कान में जो प्रेशर लगता था आपको?
कान में खिंचावट होती थी, कान में दर्द आता था, हियरिंग लॉस है राइट कान में, उसमें भी मेरे को फर्क गिरा। और कान का दर्द जो खिंचावट होती थी उसमें भी ऑलमोस्ट 50% ऐसा मेरे को फर्क गिर गया। तो मेरे को बहुत लंबे टाइम से प्रॉब्लम था, वो भी फर्क गिर गया। बाकी स्प्लिट।
So this patient was on the CPAP, last patient. So on the CPAP and the dialysis, he had a lot of drugs and he had a kidney failure. So this is the spleen, this is the occlusion, imbalance of the occlusion, only posterior contact. This is the airway, closed. This is the anterior stabilization wide, and this is the anterior equation wide. So in both the cases, the airway is more. I decided to give the stabilization spleen. And this is his testimony.
चारों भाग में पेन होते थे, बहुत पेन होने के बाद मैं बहुत सारे ब्लड टेस्ट किया। ब्लड टेस्ट करने के बाद कोई सेंसिटिव टिश्यू बोला, एक जनरल उठाना किया, फिर भी पेन नहीं था। फिर मैं मेरे को बोला कि न्यूरोलॉजी में प्रॉब्लम है, तो न्यूरोलॉजिस्ट कर भी गया, न्यूरोलॉजिस्ट में भी दिखाया हमने। तो उन्होंने भी कहा कि न्यूरोलॉजी में प्रॉब्लम नहीं है, आपका डेंटल इशूज नहीं है कुछ। फिर मैं सर के पास आया, सर ने CBCT कराया, सब चीज़ कराया, सब इलाज कराया और ये स्क्विंट दिया है। अभी 2 महीने से मैं स्क्विंट वापस रहा हूँ। माई पेन हैज रिड्यूस्ड ड्रास्टिकली। अभी मैं रात को थोड़ा सो पाता हूँ और मेरा आई यूज्ड टू बाय CPAP और ये पेन की वजह से रात को CPAP नहीं पेन पहन सकता था। अभी आई स्लोली स्टार्टेड wearing the CPAP also, CPAP machine for snoring और सब चीज़। पेन अभी ड्रास्टिकली जितना मेरे को थ्रॉबिंग पेन होता था, अभी उतना थ्रॉबिंग पेन नहीं हो रहा। थिंग्स हैव स्टार्टेड टू इम्प्रूव। ओके, ये स्क्विंट पहनने से बहुत अच्छा फ़ायदा हो जाता है, जॉब बिकम्स वेरी अलाइन और दैट्स इट। आई एम रियली
Okay. So you have seen that patient was on the CPAP also, but with the help of appliances. Now there is again therapies there, CPAP plus the appliances. So with the appliances, the airway increase, and then using of the CPAP becomes comfortable to the patient. Because whatever the therapy you give to the patient compliance should be there. If the patient compliance is not there, you will not get a result. So you need to go with the flow with the patient. You need to talk to the patient, tell the patient, ask the patient, and then go slowly with that, how the patient is following. Otherwise, patient will run away. Okay, so this is a lack of time. I cannot go further. Okay, this maximum I done. Another presentation, but another speakers are also there. So I'll finish my presentation here. So questions we'll take in the panel discussion. Okay, thank you for the patient hearing.
How many of you treat full mouth rehab? Most of you had raised your hands. Now I just want to ask you again and repeat the question again. How many of you, after Avinash sir's lecture, will first ask the patient, do you snore at night? And I thank Dr. his valuable time and inputs and being the first opening batsman and hitting a 6. So Dr. Avinash, I would just like to felicitate you. May I call upon stage Dr. Rohit to hand over the certificate, or Dr. Rajesh Gaikwad to hand over the certificate to Dr. Avinash. All the questions which you have towards the speakers will be taken in the panel discussions. So we have a designated WhatsApp group, so you can type the questions over there with the speaker's name. Thank you. Thank you, Avinash sir.